Now we are live, my friend. We still have 4 minutes, so more members will join us. So, how's everything, by the way, since I left Spain?
Everything is fine. Let me just reconnect myself because everything is going slowly on my desktop.
Yeah, that's fine. That's fine. Uh, till we have my friend Dr. Arman Ghazi again, I invite you all to attend this webinar. Uh, Welcome back,
Okay,
my friend.
that's better for me.
Yeah, we still have 3 minutes.
So I
Okay.
was telling you
Yeah,
that today was the warmest day in Belgium since many years, and
really.
it's 40 degrees for us. It's really hot
40.
because we don't have air conditioning in our houses,
Okay, I can see. I can see.
only at work.
I think you need to come to Saudi Arabia, my friend, to see and feel the real hot weather.
Yeah, I know, I know, I know, I know.
Okay. Uh, so let me just try to share my screen. Uh, Full screen. Okay. Share. Yes. Um, I think you can see
Yes, I can.
my full screen. Yes. Okay. Just 1 minute, please. Hello, everyone in Excellence in Endodontics group. Today we'll have another excellent webinar, inshallah, with my friend Dr. Arman Ghazi. Of course, this is a part of the 6 online endodontic excellence in endodontics online conference. So far, we had many excellent webinars with great speakers, and tonight we will have the great friend, my friend Dr. Arman Ghazi. Allow me to introduce him well. Dr. Ghazi is an exclusive endodontist at Endodontics Erasmus Hospital in Brussels. In addition, he is a teacher for the postgraduate endodontic program at both of the universities, University of Brussels and Rey Juan Carlos Madrid universities. I hope that I'm pronouncing it well and correctly. Also, Dr. Ghazi is a certified member of the European Society of Endodontics and one of the owners of Endo Training Center in Brussels. Dr. Ghazi is a well-known keynote speaker nationally and internationally. And myself, I had the pleasure to meet him many times. Moreover, he is very active in social media education as he is arranging webinars and he is usually hosts worldwide known endodontists. And I was one of his guest speaker last year, I think. Is that
Yeah,
correct, Dr.
that
Ghazi?
that's correct. I had the honor to having you, Ahmed.
Thank you, my friend. And of course, I would like to thank our great sponsor, the platinum sponsor, Zark for Indo Company, and the gold sponsor, Dinjoy Company. Thanks, Zark, for the excellent platinum sponsorship. And I would like to take this opportunity to thank ZAR company for inviting me and my friend Dr. Ghazi for the Global Advisory Board meeting, which was held last 2 weeks ago in Spain. I would like to thank also the golden sponsor, Denjoy company. Also, I would like to thank the silver sponsors, Dexis and Woxo, professional dental manufacturer from China, and our bronze sponsors, Ramo Medical and Ateeth. I will stop sharing my screen now. And please, my friend, can you start sharing your presentation?
Yes.
Please, members, invite your friends, colleagues to join us in this excellent webinar. I promise you, because I know my friend, we will have a lot of scientific stuff and fun as well. Is that correct, my friend?
I hope so.
Yeah. The stage is yours, my friend.
Okay, first of all, thank you, Ahmed, and all your friends that are helping. You are amazing for organizing this congress, and I'm very delighted to be part of that congress and spending tonight with you. I'll try to do my best to talking about root canal filling, but first, let me show you where I'm coming from and a little bit about Belgium. If you don't know, each time we have an international speakers, it's nice to know a little bit more about the country, and not only endodontics, of course. So I'm coming from Belgium. As you see, we are based in Brussels, and Belgium is well known for guess what? For its football team, soccer team. They are very good, one of the best in the world. Actually, they were number one in the world. They never win nothing, but they were number one in the rating in the world. So this is one of the advertising about that Belgian group. And okay, in soccer we never win everything anything, but in another thing we won two times, and not the smallest things. It's hockey. We were champion of the world in 2018, and of course Olympic champion last year. A small country, two times champion of the world and Olympic champion. And you may understand that with that hockey gamers, we sometimes have a few accidents coming to the office with teeth broken because of they were hit really aggressively. Okay, let's talk a little bit. Dr. Madarati talked about me, but let's talk a little bit about me. And I'm teaching at the University of Brussels, And we have also the endo training center, which the dentists, general dentists, are allowed to work 100% on the microscope from A to Z in endodontics, decision making up to removing the broken instruments and all the rest. I started alone my private office, and now we are 10 endodontists working there. This was the first office that we went, and since 2 years ago, we moved to a new place, specially dedicated to endo. It's at the end 7 units dedicated only for endodontics, and we have the pleasure to work in this area that which we built for all of us. And I try to act at least like a family, and having everybody in my house once a year, take care of everybody who is working with me, and I don't work with people that I don't like, so all of them, I like them. They're my family, and we are working in that kind of works. Okay. Internationally, as you said, Ahmed, I had a pleasure to see you um, several times in different countries, and I'm going all around the world. I've been building with my friend Jose Aranguren, Frédéric Buquier from Marseille, France, and Shannon Patel from London, a page, an Instagram page called Endo Update, and we try to build that up and bring more and more educations on that. And of course, as you said, I'm one of the teacher of postgraduate program of Jose Aranguren in Madrid. It's a great pleasure to be with them and spend time and try to learn. They are really, really nice people working in Madrid all together. Okay, so I'm coming from a University of Brussels, and the University of Brussels, in Brussels we have two universities. One of them is Catholic University, which is Catholic, and the other one is Université Libre de Bruxelles, where I'm coming from. Libre means free, non-religious university, and we believe that what we call libre examen, free examination. So everything that you're hearing today, you may have your critical eyes on that and try to put in balance in what you're thinking. Don't take everything I said like a Bible and do it. Please have your judgment under that and try to understand and be more critical in everything that you're hearing. Okay, let's go to the subject of tonight. It's root canal filling. But before doing a root canal filling, you may understand if I have to do a presentation on root canal filling, I will put something like 20 minutes and it would be done. But before that, we need to know the objectives of the root canal filling. When to root it, the length of the obturation, preparation of the obturation, and the ideal root canal filling. What is the ideal root canal filling? Type of the sealers, the filling material, and the techniques. Of course, I will give you 3 techniques which I'm using daily, and you will decide whatever you want if in those techniques you like something. So by the past, the success rate was based on um, what we call it triad, was a debridement, disinfection, and three-dimensional root canal filling. If we were doing all these three together, we will have success. The success was based on that. Now we understood something more, that the success must be based. First thing is diagnosis, making a good treatment plan, going for a treatment or not going, because we will know at the end there will be no success. This is really, really important. Of course, we are dealing with the strong variation of anatomy, so we have to understand, we have to know, we have to be aware of isthmus and all of um, different canals or lateral canals that we have to deal and clean. um, we still have the traditional concept of shaping and irrigating. Disinfection is really important. We are spending more and more time on disinfecting, activating our irrigants. Then the coronal seal, what we put on our root canal treatment, is hugely important for the outcome of the root canal treatment. And we will have, of course, the three-dimensional healing. And right now with the cone beam CT, we jumped a little bit more faster to understand what's going on under that. Okay, so the objectives is to have a success rate. But what is influencing our success rate? This is a publications that shows that difficult factors can come and go through that, so we don't have success. Well, if you have a periapical lesion before, it's less better, of course, than if you don't have a periapical lesion when you start the endodontic treatment. Then, if you have a void inside of your root canal filling, it's correlating with a less success rate. And of course, if your root canal filling is less than more than 2 millimeters away from the apex inside or outside, these are not good points. And of course, again, the coronal restoration is one of the key concepts for having a success rate. An early radiographic study was pointing this one, that 58% of treatment failure were due to incomplete obturations, and they found the correlations between poor obturated roots and the, the failures. Well, when you think that poor obturated root could be because you didn't prepare and clean correctly, that may correlate correctly both together. So another impact, that's iatrogenic impacts. And of course, Shannon Patel, our friend Shannon Patel, bring out a nice study that at the beginning when he was talking to me about, I'm going to bring out a study which we will change the gloves, we will change all the tray completely, go to a completely cleaned one before doing the root canal filling. So we are preparing, shaping, and cleaning. But before doing the root canal cleaning, we're changing everything. We bring new ones. We open new instrumentations that are sterile, and we work. I was thinking, whoa, yeah, wow. I don't think that they're going to bring a huge difference. Shannon went more far than me in thinking, and then he tried it. So he was taking a sample inside of the root canal on the baseline and the post shaping and cleaning just before the root canal filling. He was taking a cone beam CT, and 1 year after another cone beam CT to see how is the healing. So we were dealing with 144 molars, and at the end, when he did the recall with his group, there were only 115. Then 54 was standard protocol as we used to do. We are not changing the rubber dam, not changing the gloves, not changing all the settings, and we are still going on. And announced protocol was changing the rubber dam, changing the gloves, changing everything. Everything is clean and sterilized, and then we go through that. There was a huge difference. Why? Because if you have a look, even if the sample that he was taking after cleaning and shaping, there was a difference with between enhanced protocol and standard protocol, and the success rate. Enhanced protocol was 85% and standard protocol 66. There's a huge gap between these, so it's really important to be sure that you are cleaning everything. I was doing this for a long time. I was cleaning my rubber dam with the alcohol, and I'm still doing that. What I changed before after that study is I don't bring out all my instrumentations. I don't open them for the root canal filling. I will open it just whenever I clean everything. I bring it out and I start to use it. And I'm changing the gloves, of course. What about the leakage on the root canal filling that we have? Well, there's procedural errors such as loss of length, canal transportation, perforation, loss of coronal seal, and vertical root fractures that will reduce our success rate on the root canal treatments. There is a various experimentation method have been used to assess micro leakage after obturation, and unfortunately, none of them is concluding. The thing is, when you think that we are working in a really hostile area with lots of bacteria all around it, and we do a root canal treatment, and despite all of these things, we still have a good success rate. This is amazing for me. Okay, so we are talking about bacteria, more and more about bacteria. The aim is to clean everything, to have minimum bacteria, to start to try to go up to aseptic environment. So let's have a look. How do we clean? Well, the first activation of the irrigants is your file. So whenever you use your file, whenever you go to the root canal, you have to be full with the hypochlorite or EDTA when you're working, full irrigant when you're working. Your file with is an activator for this irrigant. Another system could be, I'm sorry, my computer is running a little bit because here in Brussels it's hot and the computer is European, so he don't understand what's hot. So we need to cooler a little bit the computer. So another way of cleaning is, of course, the mash two technique, which will come, I hope. And the mash two technique was the master cone that you're taking and pumping in the root canal system. And if you pump that cone, here is coming. Thank you, my computer. So if you pump that master cone at the working length, you will push everything on the periapical area, and the patient will have pain. But if you come out 1 millimeter upper and do that, it would be really easy for the liquid to go around the master cone and come out. So you have a really nice activation. And PMH2 were telling us do it 100 times. So I was asking Pierre, this is really boring to do 100 times. Duck, 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 duck. And he said, I'm counting, I'm counting. So if you come to my office, you will see my hands while I'm working. I'm doing 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Click, I close this one, and this one. And I go 2 times until I finish this cycle. And of course, you are allowed to change it after 50 because the liquid is really dirty, and you can change, have a new one, renewing your irrigant for doing that. Um, I will go faster for this if my computer's activator, which is vibrating to the irrigant. The problem with the endo activator, it's a be a little bit more strongly to have as well at the university, and it's working. Another way is this way. This is what we call a positive and negative irrigations. You need to have in one hand, keep it in one hand, and do positive irrigations and then negative irrigations. But you need to be aware that to doing that, working length minus 3 millimeters. Otherwise, you will create more inflammation in the in the periapical area. So it will be painful at the end of your work. Well, if it's a member of your family and you want to be painful, go ahead. But otherwise, try to be gentle while you're doing that, so you are activating your irrigant, and then you will change the syringe because all the irrigant inside of the syringe are really dirty and it needs to be changed. Okay. The last one would be the SIF system. Of course, this is a nice system. The only problem with this system is that stent is breaking sometimes. It's not the only problem. The second problem is that the device is really expensive. The motor are not that strong, and then they break really easily. So, but for me, this is the best way to cleaning your walls. And if you compare to the others, whenever you take a section on the middle third and at the end of the root, whatever, it's cleaned the same way. For me, this is the device is broken really easily. They need to review that thing. Endo activator, I was telling you, nice device, working well, More stronger would be better, of course. Then at the end, what I'm using right now, it's something we called the Z activator from Zart. That is an ultrasonic device with the nickel titanium tip. It will bring a good vibration on your liquid and a cavitation, so you will have a really nice activation of your irrigant. As you can see here, of course, you change a lot your irrigant to have a good new one to be activated. This is one dense indented that I cleaned, and I put my biodentin on that. And this is 6 months later. You see the healing is coming. The main tooth is still alive. What was infected was the enamel canal that was infected. And you can see here, this is a retreatment. Even you can have a huge lateral canal, which I wasn't able to find while I was working on that. Okay, so we were talking about the bacteria and removing these bacteria, arriving to an aseptic environment. And so if we think like that, the method of the obturation is less critical, okay? Because if we clean, whatever we do for the obturation, that's fine. Is the method of the obturations less critical? Let's have a look. This is another study done on monkeys. As you can see, they did cleaning and shaping, and in some groups, they didn't find any bacteria in the sample that they take at the end of cleaning and shaping. And in other groups, they found some bacteria. And surprise, surprise, and no surprise, where there was bacteria, there is more um, failure than on the other group, of course. So, yes, the bacteria are responsible for the failure, as we can understand. How important are the bacteria? Well, this is another study done in 1965 by Kekashi. Everybody knows this study. And he's saying what? Since 1965, we know that bacteria cause abscess, necrosis of the pulp, and all of that. And we know if we create a mechanical explosion of the pulp or perforation or whatever, if there is no bacteria, we will have healing most of the times. So this is an important thing, and we know that since 1965 by Kekashi. So no bacteria presence at the time of obturation. Well, hearing occurred regardless the quality of the obturations. And when there was bacteria present at the time of obturations, there was a correlation between the quality of the obturation and non-healing. Okay, the results emphasize the role of bacteria in apical pathosis and importance of cleaning and shaping, but not the obturation. So what I'm talking tonight is not really important. Let's have a look. Why? Is that coronal obturation, the coronal obturation, that important? So if we're talking about bacteria, let's close everything and see really the root canal filling is not important. The only thing is important is cleaning and shaping and seal it coronally, so everything is closed. Let's have a look. Well, they did the cleaning and shaping. They didn't do a root canal filling. They sealed coronally with the composite. And in the other group, they did everything like we do: cleaning and shaping, root canal filling, and then coronal seal. Results was, after, of course, 190 days, they killed the animals and they saw there were no difference. However, the results emphasize the importance of cleaning and shaping in eliminating bacteria. Okay, that's nice. But keep in mind that this is a short term study. So, whenever you have a leakage with the coronal seal that you have, the bacteria will go faster inside of the canal and going down. The root canal filling is another barrier for stopping your bacteria whenever you have a leakage somewhere. Okay? Do we have any method to determine the efficiency of cleaning and shaping procedure? Let's have a look. No effective method. The criteria of cleaning dentin walls prove to be unreliable. And what we were thinking of when your file is bent at the working land, it's working. When you go uh, three times more, so if it's 20, you go 25, 30, and 35, your apex needs to be 25. This is not proved neither. What is important for the success is the shaping tongue correctly. Think that your canal is not a really canal. It's coming, the diameter is reducing, getting bigger, and you need to give a correct shape to that canal to clean correctly. And in the apical third, most of the time, we don't spend enough time to clean. So whenever we reach the apical part, hey, it's done, perfect, we're done, let's go home. No, no, no. We have to clean. That apical third is really important as well as the rest. So if you think about that, cleaning means the degree of disinfection, shaping, ability to obturate the radical space. So you're making space, you're bringing the disinfectant, and at the end, what should have we have is cleaning and shaping is the reflect. The reflect of cleaning and shaping is our obturations. So the method that we have to understand is our cleaning and shaping that important and done correctly is to see the root canal feeling. Whoa, it's done correctly. So there's a good chance that we did cleaning and shaping correctly. This is the only method that we have right now. How can we evaluate the efficiency of cleaning and shaping procedure? We look at the x-ray. The length is okay, the taper is okay, the density is okay, sorry. The level of gutta percha removal is okay. In this case, it was easy to remove that gutta percha. The coronal seal, no way to see if the coronal seal is okay. It's not possible to assess the quality of the seal established during obturation with the radiograph. Of course, it's important to remember that no material or technique prevent leakage. That is really important for us. So, make the story short, root canal system cannot be completely clean and disinfected. We all know that. That's the big problem. Obturation of the radicular space is necessary to eliminate leakage, reduce the coronal leakage, and bacteria contamination. Sorry, we go back. I'm going faster in my head than I should. Seal the apex from the apical tissue fluid and entome the remaining irritant inside of the canal. Okay, so these are really important. What about three-dimensional obturation? Is that important, three-dimensional obturation? The canal system should be sealed apically, coronally, and laterally. So we need to be completely hermetic. Poor obturation canal and leakage are correlated. As I told you before, and radiographic evaluation of obturation does not correlate with well with leakage. Sorry. So we need to have something completely hermetic and closed correctly. Okay? So what do we have? Once upon a time we had gold, various metals, zinc oxide, paraffin, amalgam. Then gutta percha comes only at 1867. 1914, we said, hey, let's put a sealer with that. Only gutta percha since that. Okay? And after all of these things, Armand went to Rootfield. Well, let's have a look. If we have a vital pulpal tissue, initial visit is perfect. You just cleaning, shaping, and filling. Okay. Necrotic tissue, most of the time, one visit is perfect. The only thing is if you cannot dry the canal because there is an acute symptoms and pulp necrosis and huge abscess. Most of the time, most of the practitioners prefer having no symptoms before doing the root canal filling. This is a publications that goes on the contrary of that. They have a huge symptoms. What they did a root canal treatment, they fill it, they drain the abscess, and they give antibiotics. So they do everything from inside, from outside, everything, and they had success. Why not? Let's sometimes try that, but sometimes I'm not comfortable to doing in one session everything, because the patients will have lots of pain and he needs to deal with that as well. That's why in 70s they were afraid of that postoperative pain. So what they were doing is few visits to reduce the pain. Okay, but when you think about that, um, whenever you go for root canal treatment, they work a little bit. You come home, you have pain, pain plus pain plus pain plus pain. So if you put all of them together, one visit probably is the same pain that we are talking about. So whenever we can, in my opinion, we should do the root canal treatment directly at the same visit that we have the patient. So finally, when do we root fill? And well, after the cleaning and shaping procedure, when the canal can be dry, no swelling, no presence or persistence of exuda from the canal. The time of the obturations, for example, at the university, the students are working for 2 hours. After 2 hours, let's say to the patient, you stay 30 minutes more, they're going to kill themselves. So sometimes we postpone that. On the other hand, if the patient is not capable to stay for 1 hour and a half, for example, and we do 45 minutes every time, well, we need to do it in several visits. And how far should we do the root canal filling? Okay, so the important things for everybody, as you see here, is the dentinocemental junction. Perfect. As we know from the university, it's that cone that goes there, and we have to stop in dentinocemental junction. We have one only problem, that it's irregular part. And we saw with the publications of Yuri Cutler, which was the father of Sergio Cutler, that this dentinocemental junction, sometimes in mesial part it's a bit higher and the distal part a little bit lower. It changed with the ages. If you have a resorption, it's changed. So we really don't know clinically where is that dentinocemental junction. What we suggest and what he suggests was to reduce 1 millimeter, because it's always better to be inside, clean everything, but obturate a little bit inside than overfilling. Why it's important to control the length? Well, because you will extrude some debris and root canal filling, and when we hear that, we hear bum bum bum, one light saying, "Hey, postoperative pain for the patients coming." Okay, this is another study. Why we should be inside and not outside? The Gula Bilbala groups bring out that whenever we are outside, it's correlated with more failure than whenever we are inside, and of course the postoperative pain. When you think about the 22 months following just after root canal treatment, there's no significations between being overfilling or a correct filling or inside filling. But if you go a little bit beyond that 22 months, you will see that long-term talking, we will have more failure with overfilling than being inside, of course. And of course, the other problem with overfilling, that over preparing our apical foramina. That means we may create some cracks when we are forcing that apical foramen. We need to respect the anatomy, of course. What about the histology? I think everything, I hope everybody is still awake. I'm still awake. What about the histology? Well, when we talk histology in endodontics, we are talking about Mr. Domenico Ricucci, who brings out that, um, well, if you're beyond, so if you have overfilling, it's not good. And if you're more than 2 millimeters shorter to the apical part inside, that means you have a big space that you didn't clean correctly. Well, it's not good. So the best would be in that 2 millimeters next to the apical part inside. That would be the best histologically. About the smell layer, when we get out, when I was graduated, we were talking, hey, let's leave the smell layer there. You remember we have the same discussion on the for the composite and all of those things. Well, let's see. The smell layer is prohibits the sealer to have a contact with the wall. So it's between the sealer and the wall. So your sealer cannot get in the tubules, and of course it's not okay. And you have lots of food for the bacteria inside of the smell layer that help them to grow, of course. And it's interfere with the action of the irrigant on the wall, adhesion and penetration of root canal sealer, as I told you, and penetration of thermoplastic gutta in technique. Well, the smell layer is just a parasite in the middle of our work. But if you remove it, you have a better adaptation of your root canal filling material to the walls, and of course, no smell layer, no food for the bacteria. So please, no smell layer. That's why we are activating our irrigant. Finally, what is the ideal root canal filling material? Well, if you follow the Holy Grail, the American Association of Endodontics, they said root canal sealer are used in junction with the biologically acceptable semi-solid or solid obturation material to establish an adequate seal of the root canal system. So you have to manipulate, you have to be able to bring it three-dimensionally fit inside of your root canal system. And of course, the paraformaldehyde containing paste are forbidden because of the problem of they are cancerogen, so it's not okay. Remember, the obturation root canal should be reflecting the original canal shaping. Your shaping should be like the original canal, a little bit bigger, and so your obturation should be like the original canal, a little bit bigger, of course. Do we really need sealers? Because we are cleaning, remember, we are removing all the bacteria. So who cares about the sealers? We just fill the space. That's all. Let's see, why do we need the sealer? Well, to seal the space between the gutta percha and the wall. There's always a void space. We need to fill that space with the sealer. We need to have a sealer that do the junction between the gutta percha and the wall correctly. And of course, these sealers, you know all that it's like a lubricant for our gutta percha cones to go up to the apical part, and it is entombing the microorganism or irritants inside of the root canal. It's going all around it and keep them in the same place a little bit. This is what Mr. Grossman will bring out about the sealers in 1988. If we go through this, we will understand at present no sealer satisfy all the criteria, of course. So this is not the point. We have a criteria. No sealer is doing that. Amazing, no? What do we need at the end, finally? We need biocompatibility. We need well tolerance by the periapical tissue. And what do we have at this moment? We have toxicity. Wow. And it works. That's perfect, no? What do we need more? We have toxicity and it works. Let's have a look. Why do we have toxicity? We have toxicity during the setting time. If the setting time is really high, well, we have toxicity for long term. If the setting time is short, we have toxicity for short term. That's the point. So let's see the most popular sealers, and let's go through that and see how are they for us now. We have zinc oxide based cement, we have calcium hydroxide based cement, glass ionomer, resin based, uh, silicone, and calcium silicate based sealers. Okay, all exhibit toxicity until they have set. We have this in mind. Okay, extrusion of the sealer. So if you think about that, extrusion of the sealer is not okay. Try to be inside, not outside, please. Okay, don't do any extrusion, please. Okay, zinc oxide and oxygen. Well, they are resorbed if they're extruded. That's a good point. That's a good point, but they are resorbed. That means leakage. Slow setting time. Slow setting time, remember, setting time brings toxicity. Shrinkage on setting, solubility, and stained tooth structures. That's not okay. antibacterial activity and toxicity because they have a long setting time and they are resolvable. So they bring antimicrobial activities. What about the calcium hydroxide? They put calcium hydroxide because it have antimicrobial activity, but it's resolvable, slow setting time, shrinkage, solubility, and stain to structure. And of course, the good point is because of that pH, high pH, because of high calcium hydroxide, we are reducing the inflammation. But actually, we put the calcium hydroxide at the beginning for another thing, for having an osteogenic potential. But there have been no proof, no demonstrations of that. Glass ionomer, no addition to Guttapercha and canal wall. So this is not okay. We have a material that is in between two things, and there's no addition. It's not bending the other one to the other one. We have the conditioning agent to put on the wall to have an addition on the canal walls. Retreatment is difficult if you have lots of that material, it's glass ionomer, and minimal antibacterial activity, but still have antibacterial activity. And it if you put the conditioning agent, you can have a good bonding to the dentin, of course, not to the Guttapercha. Epoxy resin, this was hugely used, as you know, AH plus from Densefly, slow setting, remember setting toxicity, but the good thing is sealing ability and working time 4 hours. That was a cement that you're starting in the morning and you can have all the morning when you're an endodontist. But if you think about the publications of Shannon Patel, well, I am doing for each patient a new one for treating. So I have no bacteria coming from whatever. I'm clean in every way. Silicone sealers, not with all Guttapercha. This is Seal that is used. Actually it was a really good material, but the point is it's going correctly with the Guttapercha coming from Colten, but with other Guttapercha it's not working correctly, and the setting times it's 30 minutes. So it's less, so you don't have lots of time to have it. Regarding the other ones that we were using, to use the same from the morning up to 12 o'clock and then changing. Uh, Expand, the good point is that they expand slightly on setting, so they are filling the space a little bit. And single master cone, so you were putting that and then a single cone and cutting your cone. Remember, they have the Gutta Flow that was with small piece of Guttapercha inside the sealer that you were injecting, and you're putting the master cone and cutting. That was a good obturation as well. So they have a sealer, and it goes with Guttapercha, of course, the Roico one. Just to summarize a little bit, most of the one that we were using, it's a Zoe based calcium hydroxide or resin. Sorry, the resin is written in French. So if you look at the left column, you will see those two things that are important in this: adhesion to dentin and adhesion to Guttapercha. If you see, the only one that is responding to that, it's the resin-based sealers that have a good adhesion. That's why we are using them a lot. Um, and now we are changing a little bit with the new calcium silicate sealer that have, of course, a long setting. Well, they are reducing the setting and they have the fast setting coming more and more. What is important is the positive part, is that they have bioactivity, as you can see here. Uh, we have cement coming at the end, closing the root canal system. Hydrophil is really important because they can go exactly on the tubuli. They can use the moisture of the tubuli to set correctly, non-staining, dimensionally stable, and of course antibacterial because they are releasing calcium hydroxide. Just be careful for one thing, that some of them are with resin based And there is a mistake on my slides. I wanted to talk about two things. An example of this sealer is neo-sealer flow, which is not resin based. This is just an example for the sealer that we are talking. But pay attention on those with the resin based. There's no meaning to put something that is really biologically tolerated with resin, which is toxic biologically. So this is just a marketing way. Just be aware of that when you're buying something. So let's compare. If we see here, this is coming from Pathway of the Pulp. We have the ISO, which need to respond for a sealer, is this. Okay. So AH plus is okay. He is responding to that criteria of ISO. MTF Filapex, by the way, MTF Filapex is the one with the resin-based sealer, um, is responding, and endo sequence is responding as well to that criteria. And of course, even the MTA, which is not a sealer, is responding to that criteria. But we still have toxicity, and that toxicity is coming from the calcium hydroxide. So we're not talking about the same toxicity. That toxicity is interesting for us if we didn't, of course, uh, achieve a complete removing of the bacteria inside of the root canal. That will help a little bit more to reduce. And the calcium hydroxide is a high pH that is interesting for the inflammation. This study shows how it goes with the toxicity. If you see on the top, you have Teflon. Then the square is AH plus. And after 6 weeks, AH plus is no more toxic. What does it mean? That means it takes 6 weeks for the setting time. And then no release of toxicity. That's okay too. You see, the endo sequence, which is a calcium silicate 7 sealer, sorry, it's coming nearly after 6 weeks, reducing the toxicity. That means still after 6 weeks, releasing calcium hydroxide. But the worst one, that was the one that we used for a long time by the endodontist, it's a pulp canal sealer, EWT. EWT is extended work time. You are mixing in the morning and you're still using at 8 o'clock in the evening. And this one is severely toxic, and endodontists were using that for long, long, long time. So please, no more using that at all. All of them, the first days are highly toxic, as you can see here. Okay. I need to remind another thing. When we are talking about the calcium silicate sealers, something is happening in the bone all the time. Just put the calcium silicate away, come back to this slide and see. So we have osteoclast eating constantly the bone and osteoblast building the bone. That's we are remodeling the bone all the time. All the body is doing that. Me, you, our friends, Dr. Maderati, of course, and Dr. Jose in Madrid. Okay, another thing, when we have the pre-osteoclast, this is the pre-osteoclast. For changing this pre-osteoclast to an osteoclast, for eating the bone, we need the rancle to link to rank. Then it's changing. Differentiations is going, and we have osteoclast. To inhibit that, we have the OPG coming. And if we want some OPG coming, then you can influence having more OPG by, you see, interleukin 4 and interleukin 10. These are the two importance that you have to know on this slide. And that will inhibit the differentiation of pre-osteoclast to an osteoclast. Okay. So if you have lots of OPG, what happens is we are reducing the population of osteoclasts, and on the other hand, we're still having the population of osteoblasts coming. So we can change this balance. We will have more osteoblasts and less osteoclasts. Well, theoretically, we will have a good, more healing faster than. That's why it's bioactive, okay? And we can see here, but these publications of Dr. Alexis Godon, who is the teacher in Nantes, it's a city in France, who tried with the Bioroot RSC, with the ProRoot ES, and MTF-Filapex, and see how it goes. With Bioroot, we can stimulate the release of interleukin 10 and interleukin 4. With ProRoot ES and MTF-Filapex, only interleukin 10, and of course AH plus, which is a resin-based cement, nothing is released. So if we come back to here, well, we have interleukin 4, we have interleukin 10. So we are theoretically stimulating, having more OPG, and inhibiting the differentiations of osteoclast. That means we can change the balance from having a big resorption, change the balance, and bring faster the healing. Okay, for that, we were mixing lots of the time this Bioroot, for example, which was one of the first on the market. We were mixing, and that was the main complaint of the dentist. The using that, the manipulations of that were difficult. Now we have injectable ones that are really nice, and the tips are getting better and better. Be aware of the tips that are using too much sealer inside, that you will throw away because it's inside of the tips. These kind of tips are really nice to be used. So on the market, the three important ones are these three importance, which are neosealer flow, endosequence, and AH plus bioceramic by Densefly. When we have a look, this is coming from a publication of Dr. Walsh. When we have a look on what is inside, we can see that the bioactive cement, which we need and which is interesting in this kind of cement, is sometimes really different between one to the other one. And the most one is, of course, neosealer flow. And when you see the AH plus bioceramic, it's only 9%. But on the contrary, dentists love that cement. Why? Because if you see the radio opacifier, it's 91% on AH plus bioceramic. And of course, this is really nice to see what we are feeling. But with those kind of material, we're not only looking after the image, post-operative image, we're looking for that bioactivity which is in the sealer. So it might be more interesting to go to a better one which have more bioactive cement inside. And of course, the stabilizer is always a good thing to have. Then here, another thing that is important on a sealer, not on the one that you're using for perforations or for a pulp capping or whatever, but on a sealer inside of the canal, what is important is the size of the your bioactive core. The smaller it is, the better it is, because the faster it will penetrate in the tubuli and hydrate faster than larger particles. But as I told you, for a filling or pulp capping or a root end filling or a surgery, there's nothing changing. So there's nothing to have small or big. That doesn't influence anything. Okay. Another thing, with this kind of sealer, we've been told that you cannot heat them. That was difficult for us because most of us were using the vertical warm vertical compaction, or by Max Padden system, Guta condenser, was that condenser. And the only one who is responding to that is right now the neo sealer flow, which you can see on the right upper one. We are putting them on a plate that is heated as at 190 degrees, and you can see the alteration of the cement that is used. The sealer is really alterated. The two down next to AH plus are from endosequence, and two different ones. The high flow is nearly okay, but you can see all the rest. If you warm them, they're no more a sealer. no more usable. The one who never changed anything on that is Neosphere Flow. And you can see here in one of my root filling material, what I did on the distal one, I did the warm vertical compaction. And on the two others, I did only the single cone technique, just to let you see how it works. And it works correctly in all of that. So it's no problem using um, heat on that. So how do we put that? Well, you just inject, and then you put your cone inside. You move a little bit up and down to let the sealer go everywhere. And actually, with this kind of cement, we're not calling them sealer. These are really what we can call feeler, because they are feeling the rest of the space next to the gutta percha, and they are bioceramic silicon based cement, so they are really bonding to the dentin correctly. So they are filler and not sealer for me, as you can see here. And this is the result at the end. And for washing them, it's really easy. They are hydrophile, as I told you. So you just wash at the end of your work. We love to take a picture at the end and send it to the general dentist, so he knows whenever he remove the temporary filling what he will find before removing that. And as you can see here, it's completely clean. We can take our picture and send it to the general dentist. Okay, we talked about the sealer, filler for this one, but what material? The gutta percha is the best one or not? Let's have a look. And this would be probably the last part before the two other system. Mr. Grossman bring out a huge list again of what we have to use, but none of the what all the things that we have respecting fully the list of Mr. Grossman. But the gutta percha is biological, okay, with the tissue, antibacterial activity, no resorbable, and no allergies. I have seen no allergies to gutta percha until now. So what? Perfect. Now what we should do? So let's go for the gutta percha, and what then? Well, we will choose our way of doing the root canal filling. I showed you one with the single cone with the calcium silicate sealer filler, and now the two others that I'm using at the university. For myself, 90% of my time it's calcium silicate based cement that I'm using, and the rest I like to play with both of those two systems, thermocompaction or warm vertical compaction. Which one we should use, of course. Let's have a look. Well, the max pattern compactor was a Hedstrom file putting on the other side and using that was with friction, soften the gutta percha and move apically the gutta percha. I'm using Z condenser because it's 21 millimeters and it allows me to work correctly everywhere. And well, first of all, you try your master cone in hypochlorite. Don't forget that you need to disinfect your master cone before using that. These videos are coming from University of Lyon, which is in France, of course. And then drawing the canal with your needle, you can do the negative pressure to remove most of the irrigant. Then with the paper points, do the rest. Then fitting the master cone, we are cutting 1 millimeter. Why? Because when you soften the gutta percha and push it to the apical part, it will go a little bit more. So if you don't cut, you will have an overfilling. Then you put the sealer. You can put it with a file, you can put it with the paper points, or with your master cone directly. Go inside, and then the compactor. You go, of course, you put the stop 3 or 4 millimeters shorter than your working length. Then you activate and you go up to your stop, and then you come out. As you can see here, it softens the gutta percha, and then you go slowly inside It's pushing you outside, but you resist and go slowly inside. And the way that you should come out, if I can explain it like that, it should be like this. As you can see here, you're moving and coming out, moving and coming out, moving and coming out. So with this kind of working, you avoid the bubbles inside, and you can feel correctly all the space inside of the canal. Then you remove, of course, if you have the gutta percha inside of your port chamber. Okay, so to summarize, you try your condenser 3 or 4 millimeters shorter than your working length. You try to mask the cone, you put the sealer, and then you activate. You go up to your stop, then you come out slowly as I showed you, and it's done, finished. Just be aware that we have a compactor fractures. It's okay with that because we can use it for other patients that don't open much. That's a good thing. Risk of overfilling if you insist or if you don't cut 1 millimeter from your master cone. In the curved canals, it's not going correctly, and we will probably have in a few months one Kota condenser, Z condenser, um, done with nickel titanium plastic one that will allows us to go a little bit further in the cove canal and fill them. And if you have an open apex, of course, it's always dangerous to push a little bit because we have no control in the apical part correctly. Good thing is good apical condensation, little material, fast technique, and very low cost, of course. This is one of the works from one of our students in Madrid who is finishing his postgraduate program this year. And you can see how much we can heat inside of the tooth while we are working with the gutta condenser. So just be aware of that and think of your periapical ligament. Do not put too much heat on that. And whenever it's softened, come slowly out to reduce the heat. Okay? Another technique is warm vertical compaction. And before doing warm vertical compaction, sorry, we were doing an old way of doing that. That was heating, putting the gutta percha, heating and then plugging, heating and then plugging, heating and then plugging. And at the end, putting small plug of gutta percha warm and compaction, 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 and finish. Now, what we're doing is continuous warm compaction technique. What does it mean? That means that we can heat and plug with the same plugger. We don't heat and plug. We heat and plug with the same plugger and same moment. That's interesting. So we can heat and go down with the same plugger. We have more fluidity of the Potaperca going three-dimensionally, and then with the Z up, we can put the gutta percha inside and come out. Okay, and still we are cutting 1 millimeters of our gutta percha because we are pushing the gutta percha a little bit further to avoid any overfilling. We can do that. Let's see one of my cases, what I did here. Let's go. So everything is clean. Now I'm drying the canals. I'm using my paper point for finishing to dry the canals, as you see here. Please, every time you remove your paper points, check if it's enough or not. It's really soft, so I'm going to use another one to be sure that everything is dried correctly. Then the sealer here, and here is an AH plus resin based one that I was using. You cut the first part, then what is important to do is do a small plug of your gutta percha. So when you come back for the continuous wave, you have lots of gutta percha that you push. You see how I'm applying the sealer on the walls? Okay. And of course, I'm not doing the down packing on the my mesial part because I have two root canals. And if I do down packing, not putting on the other one a cone to block, with my isthmus, I will have with the perica blocking the other canal. So I'm preparing all of them. And then I do my down packing. Here we go with the down packing. You see my stop is already prepared. Working length minus 3 or 4 millimeters. I warm it up. I go a little bit, pushing 1, 2, 3, 4, 5. Then again, warm, going down 1, 2, 3, 4, 5. And then when I reach my stop, I will warm it up, turn, and remove. Now I'm plugging the apical part, apical third that I just filled. And for the rest, I will use the Z up. I do the same with the others. As you can see here, I'm stopping. And think of the chewing gum that you may have. If you're not pushing on the chewing gum, it comes back on the same place. So when you're pushing on gutta percha, keep pushing and stay. 1, 2, 3, 4, 5. And then remove. It will go on the other one. So this is important to keep pushing even if you stop warming. Then you remove. Okay, do not back, 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 back. This is like a chewing gum. If you do that, it comes back on the same place. But push and stay as much as you can, and that's the best. See here, I'm pushing, pushing, pushing. Okay, now fill the rest with the gutta gun, which is set up here. It's really easy because you can put a small piece, you plug, a small piece, you plug. And honestly, if my nurse is well trained, I love this obturation because it's like playing music. Everybody is working his space, and you're changing everything, and it goes really fast. And for the patient, this is really impressive to see how we are connected and synchronized together with my nurse. Our patients have a screen on the roof so they can see exactly what I'm seeing on the microscope. If you have the chance to do that, do it because they will love your work. Don't be afraid of that. Okay, then at the end, what I did, I covered my work with this ultra flow from Care, and this was done like this. You see the ultra flow. I have the Fuji for closing, and in the middle the Teflon, which the general dentist can remove and work easily after that. So, bad point, by the past, we were supposed to make a big preparation. Sorry, I was giving a lecture in Spain, so these two words are in Spanish, but big preparations, that means by the past, the pluggers were really big. So now we have really small pluggers. We can work with the taper of 2%, 4% taper, 0.25. So it's easy to do that. And technically difficult, I'm not sure. If you synchronize with your nerves, it's really easy to do. We have a good condensation apically. It's a secure technique. It works correctly, and you can go through the curved canal and long canals, and it's not really expensive if you are not thinking of buying those materials. Even buying that, it's not expensive because you're using that for long years. The only thing that I wanted to let you know is again the same work from Dr. Uzwal Moya that shows that you can heat really high inside and it goes to the periapical ligament. So be careful when you're using that. Don't heat and stay there. Heat, go until where you want to go and stop. Okay? Don't force on heating, please. So I hope I've been through all of the things that you want me to talk about it. And this is the time for me to pass to Ahmad for the rest. I don't. We don't hear you.
Sorry. Thanks a lot, my friend Darman. Can you hear me now?
Yes, yes.
Thanks a lot for the informative and excellent presentation. I think we have some questions, and myself, I have two questions actually, and I will start from the where you ended up about talking about the heat. Uh, I guess it was a study, right, or just something that you were testing regarding
No,
the
it's
heat?
it's a work of one of the postgraduate students. It's not finished yet.
Okay.
He's working on that. He just sent me last week the videos because he knew that yesterday, to be honest, I talked about this seminar for Belgian people, and
Mm-hmm.
today for you. So
Mm-hmm.
he sent it to me because I asked him send it to me.
Mm-hmm.
That's all.
Mm-hmm.
But it's not
Oh.
finished yet.
It's not finished because I wanted to know the members are definitely they are furious about this point. What is the maximum temperature that the periodontal ligament can accommodate without any irreversible changes? Can you tell or not yet?
Not yet. I'm not sure about that. But for myself,
Hmm.
if you go more than 40 or 50, I'm not really comfortable.
Hmm. Okay.
Mm.
Uh, we have a question here. When you do a single visit, do you do occlusion reduction,
No,
and you don't think it's necessary?
no. What is creating the postoperative pain? Occlusion reduction for postoperative pain, right?
Mhm. Yes, for relieving pain. Yes.
Yeah. What is bringing the postoperative pain is the debris that you're pushing outside of the root canal to the periapical area. Okay. So
Mhm.
we have tools now for be aware of that and not pushing them. We can try to not go with all our fines hitting the apex. For example, this today I was complaining with one of the students that was working on an infected tooth, and she did directly went to the working land. And I said, "Why are you doing that? You're bringing with your fines all the bacteria of the apical area. So this is a
Mhm.
bomb for the body. Please do two-thirds and then one-third. So you're reducing the charge of the bacteria before getting on that area. So reducing the risk of having the pain. This is one thing. The other thing is the irrigations. We need to be as close as we can to the apical part, but not really at the apical part because we are creating. You have irrigations, you can move activation as well. We don't have to really be aggressive while we're working. So this is one of the important things. The other things um, with the calcium silicate based sealers, we can see that we have less inflammation. And for myself, I can see that most of the patients, because we are calling the patients the day after all the time, patients are called the day after to see how they go and all that. And there's less pain with that when we are using that than with other sealers. I don't know, because of reducing the inflammations or because I'm trying to be more and more careful by times. um, Honestly, we have there are research on that they are inducing some inflammatory cells, lymphocytes that are coming for how can I say, for reducing the inflammation. Okay, we have some moderator for the inflammations that are come uh, on the site and moderate the inflammation.
Mhm. Thank you, my friend. I have some questions, but unfortunately, uh, they are not that clear. So I urge all members, please, when you want to ask, can you be more specific? For example, here I have a question. Do you prefer to crown to insert crown after the root canal treatment directly, or you wait a little bit?
It's really up to the practitioner.
Hmm.
For myself, I mean, it's not a matter of week.
Hmm.
If you're more comfortable with the patients having no more pain than putting the crown on that, it's okay for me. But if you have really a weak part of coronal part, I would prefer to protect it as soon as possible. This is
Hmm.
one thing. This is the only important thing. The rest, there are studies that shows that within 4 months, putting a crown on the tooth, we have less failure than if we wait more than 4 months. And the
Hmm.
other studies are showed within 60 days. So it's not a matter of 2 weeks. Okay, it really depends on the to the practitioner. Most of the practitioners prefer wait a little bit, but it doesn't mean that you have to wait 2 weeks for sealing your work. The sealing your work, putting a composite covering and close it, do it immediately.
Hmm.
If you want to wait a little bit for the crown, and if you have a good resistance of the coronal part, not really risky, why not? It's okay.
Hmm. Um, I have a question from Dr. Shuaib. Uh, it's not that clear, but I guess he's talking about the property of the sealer in case of periapical lesion. I guess that his question is about whether you prefer, and whenever you have periapical lesion, do you use specific sealer?
Mm.
This is what I understood from the
Yes.
question.
Whenever I have a periapical lesion, I will use the silicate-based cement sealer because of that property that I showed you with the OPG and Rankel and the differentiation of pre-osteoclast. So I will
Mhm.
try to change the balance and have a healing faster, of course. And of course, again, with the release of calcium hydroxide, I'm more comfortable.
Mhm. I have a question myself. You remember, my friend, when we talked about in when we met in Spain with the other colleagues about the temperature and its effect on the bioceramic sealer.
Yeah.
I think it's very useful for and very good for our members to bring part of that discussion here in our webinar and
Well,
highlight some facts about this, or let's say experience of our colleagues and including yourself. What is the maximum temperature that you use when you use bioceramic sealer?
this is the same temperature that I use when I do the warm vertical compaction. Okay, so
Mhm.
it's 200 for me. But I remember when we were there, some of them going up to 300. I'm not
Yeah,
comfortable with it. I'm not
yeah.
comfortable because of the periapical ligament. I'm worried about that. So I'm
Mhm.
really not comfortable. And I think that the gutta percha that we have is okay with 200.
Yeah.
One question I was, if you remember, I was asking when we saw this heating of the sealers. Uh, I know that there are studies going on the sealers because if you see the texture of the sealer is still okay for the neo sealer flow, okay, from Zark,
Mhm.
but um, we need study to see if
Definitely.
chemically they are still bioactive or something changed chemically. That's the study that is going probably in a few days starting.
Yeah, that's definitely. We need a study to make sure that this temperature doesn't affect the property of the sealer and
Yeah,
doesn't affect the bond of the sealer with the dentine of the root canals.
yeah, exactly.
That's,
But keep in mind something. So the texture is okay for feeling, that's perfect. It goes.
yeah,
We need to see if chemically it affects what we need, like bioactivity.
yeah,
But keep in mind that the heat is never going up to apical part. So
yeah.
the sealer that is on apical part normally didn't receive any heat.
Mhm. Mhm.
So it
Yeah.
should be fine, in my opinion.
You should. For me, as I told you, if you remember, I'm using 150 because I'm still feel that it's safer than a higher temperature. For you, you are using 200, the same like when you use other sealer. So we
So
are
you're
always
wiser than me.
sorry.
You're wiser than me.
Uh, 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 and we are both wiser than Dr. Ryan. If you remember, he mentioned 300. We have another question. Uh, in case of big apical infection, uh, whether I don't know if they mean apical lesion or if you have a lot of infection, if you extend your sealer to that area, does it affect the healing process? So it's if you have a big apical lesion and the sealer is out, do you think that it will affect the healing process?
Well, with this calcium silicate base, I'm more comfortable than with the rest, of course. I prefer not having, but if I have it, it's okay because they're going to be removed really fast and it's okay.
Mhm.
And to give you an example, at the university, whenever I have students working on lower 7 or 8, I don't allow them to use another sealer because if they go in the nerve the canal of the lower dental nerve, well, this is a problem. But with the calcium silicate one, it's not a problem. So I don't allow them to work with another sealer on those cases. And for myself, when I'm not really comfortable about the proximity of the nerve, well, I will use the calcium silicate one.
Okay. We have, is it necessary to fill the canal with the sealer before putting the Cotebercha cone?
With this kind of sealer, um, we started, if you see the history, we started with bioroot, we were mixing, and then I was taking it with my master cone, putting inside, come take another one, pumping a little bit, and then getting inside. Okay, this is one way, but it's easier to have it inside, injecting that, and then pump it slowly and get inside. The study shows that we have less void when we do that than the
Mhm.
rest. That's the only thing.
Okay. Mhm. If the Cotebercha cone extruded or Cotebercha extruded beyond the apex, do we have to remove it immediately, or shall we wait till the tooth is symptomatic? Then we can do something.
Honestly, it's not a big deal actually. Most of us have Gotaperca extruded and we have bone all around it. But if you look at the literature, we have more failure on those kind of cases than the rest. So if you have the opportunity to remove it directly, correct it, and put it back, why not? If you did with the gutta condenser or vertical compaction, it's nonsense to go again on that. Let it heal and see how it's going.
Yeah, and I always tell colleagues that as long as we did good disinfection of the root canal and we did proper obturation with the apical seal, we don't care about the extruded cotibercha because it's a matter of disinfection and filling the root canal system rather than the cotibercha because in theory cotibercha is biocompatible material.
Exactly.
Yeah.
Exactly.
Uh,
We have seen lots of bone coming around the gutta percha. I have one of my colleagues who make a huge round with the gutta percha inside of the bone, and we have bone all around it, but it's not 100%.
Yeah. So we assume that those cases that fail with the extruded cotebercha, the failure is not due to the cotebercha itself, rather than improper disinfection of the root canal or improper of obturation. Right? Do you agree with me?
Um, no, in those cases we will have postoperative pain. If there is a failure, it's because of the leakage somewhere, or we didn't clean correctly.
Yes.
Okay, and if I have to review that, I will keep in mind the surgical way as well.
Mm. Yeah. Uh, in case of large variable, the experience done to prove that one brand of bioceramic sealer could resist to temperature has not in fact proven just the consistency stability, not biological properties.
No. That what was we were saying, that
Yeah.
we need more study about the if it's still bioactive or not. And as I told you, we're not hitting at the apical part, so it's just a matter for us to know.
Mhm. I think we have a question. I just read it a few minutes ago. Is there any sealer that can stimulate bone formation?
Hmm. Yes, that one.
The bioceramic sealer,
Yeah,
right?
right now, the bioceramic one.
Yeah. Uh, we have a question in Arabic, so I'm going to translate it.
French, please.
Yes. Some cases after obturation, after doing root canal treatment and after obturation, the patient might encounter a swelling, but without pain. Okay. Uh, what do you think the reason for such swelling?
This is a flare up, no?
Mhm.
It's a flare
Assuming
up.
that we assuming that we disinfect the root canal properly, so nothing to do.
It's an inflammation.
Okay,
It's an inflammation. A flare up is an inflammation completely. So
it's just
we
a
need to,
reaction.
yeah, it's a reaction, and we need to deal with the anti-inflammatory at first.
Mhm. I think that's it. We've done with all question. Hopefully, I didn't miss any question. If I did, so please, my friend Dr. Arman, we would like to ask you if you go kindly to any new question that might come up and answer those questions in the group, if you don't mind, later
With
on
pleasure.
in your free time.
With pleasure.
Now I will ask, I'm going to reshare my, uh, can you see my presentation?
Yeah.
So this is a kind of appreciation to you, my friend, for your excellent webinar. Thanks a lot, my friend, Dr. Arman Ghazi, for this excellent webinar, informative presentation. Uh, I would like to also remind all our members that you can win one of our prizes by filling in the Google form, and you need to just invite your friends to join in the Excellence in Endodontics group, and you can invite as many as you want of your friends. Thanks to all our sponsors, the platinum sponsors, Zark for Indo, the golden sponsor, the Enjoy Company, the silver sponsors, Dexys and Coxo, and our bronze sponsors, Ramo Medical and Eteeth. Thanks a lot for all you members, lovely members, to attend this webinar. And we hope to see you again. Thanks a lot, my friend, Dr. Arman.
Thanks to you. It was a pleasure to sharing this with you.
Our great pleasure. Thanks a lot.
Have fun. Thanks.
Bye bye.